Okay, good morning. Today we're going to discuss innate immunity and inflammation, which are basically the first and the second line of defense. So the first line of defense we're going to discuss that is basically mediated by physical, mechanical, and biochemical barrier. Second line of defense will be the inflammatory system, and we will learn all the cascades of inflammation and all the pro-inflammatory mediators that are released during the inflammatory process. In the third line of defense, we're going to discuss the adaptive immunity. This video basically entails several more videos. It's like 4 to 5 videos in it. So before we start, the immune system is designed to defend the body against foreign or dangerous invaders, which are basically the antigens. Those include microorganisms such as bacteria, viruses, and fungi, parasites, cancer cells are also antigen, and even transplanted organs and tissues. To defend the body against these invaders, the immune system must be able to distinguish between the self and the non-self, which is basically that foreign organism, which is the antigen. What is an antigen? Because we have talked about antigen and we haven't said the definition. Again, basically it contains bacteria, viruses, or any other microorganisms, even including cancer cells. Antigens may also exist on their own, for example, as food molecules or pollen. A normal immune response consists on recognizing a potential harmful foreign body or antigen, activating and mobilizing forces to defend themselves against this antigen. If the immune system malfunctions or mistakes the self for the non-self, then we could develop autoimmune diseases. That is a part of the third line of defense. Of course, disease processes. Now let's start talking about the first line of defense, which basically is the physical and mechanical barriers. In the physical and mechanical barriers, the skin, which is basically the most important physical barrier, that's the epithelial barrier. When this is damaged, it will provoke a local or systemic response, which is the inflammatory process, which is the second line of defense. Then we also have in the GI, in the GU, and the respiratory tract, other natural barriers, which are, for example, we have the mechanical cleansing in the surface of the GU tract. The goblet cells, for example, that are present in the upper respiratory tract that produces mucus. So when a patient has chronic bronchitis, for example, or acute bronchitis, the reason why the patient produces mucus production is because of the goblet cell. Other are flushing, vomiting, and the presence of cilia, for example, in the intestine. When these cilia disappear in the intestine just because there is an acute or prolonged diarrhea, patients might have malabsorption syndrome. Then we have biochemical barriers. Those are the substance to destroy pathogen, such as mucus as well, present in the saliva and tears, earwax. The earwax is a protector. I understand that when it's abundant, is not a very good thing to look at, but it is a protective barrier against the traumas and damages to the tympanic membrane. So you shouldn't be sticking Q-tips and foreign bodies to clean the excess of earwax. The earwax should be eliminated just by cleaning the outside of the ear, not the inside. In addition, we have sebaceous glands in the skin that secrete antibacterial and antifungal to protect the body against gram-positive bacteria. Remember that we have staphylococci and streptococci that are normal flora in the skin. In addition, we have several chemicals in the epithelium, such as, for example, cathepsin and defensins. Those basically attack bacteria, fungi, and viruses. They also have proteolytic enzymes that are activated in their presence. Collectin, for example, secretes a surfactant in conjunction with the alveoli. And it does contribute to protection by producing monocytes and macrophages. You would see the function of the monocytes and macrophages are phagocytosis. In addition, we have defensins in the intestine, in the urinary tract, and also in the respiratory tract. If you remember, we also have lactobacillus. Lactobacillus is present in the vagina. When the woman exaggerates on, hygiene, there could be a wear off or wash off of lactobacillus, and patients could get candida or fungal infection. In addition to that, there's lactobacillus in the intestine that could be eliminated with prolonged use of broad-spectrum antibiotic, and patients could obtain Clostridium difficile as the opportunistic infection. In addition, you know that part of the normal flora is the vitamin K that is necessary for the coagulation cascade, which we will discuss here during this PowerPoint presentation. Then we have the second line of defense. The second line of defense is the inflammatory response that is activated in the presence of infection, mechanical damage, oxygen deprivation. We already studied yesterday or during this week how important is the Krebs cycle and what happens when there is ischemia or hypoxia, that the body deviates the cascade, and instead of production of pyruvate, there is production of lactate. And also substrate phosphorylation takes place, and there is the byproducts of the metabolism of anaerobic, which is the production of ammonia and production of ketone bodies. Nutrient deprivation is also a factor to activate the inflammatory cascade. In addition, extreme temperatures such as hypothermia or hyperthermia, ionizing radiation as well is the, part of the biochemical factors that could activate the inflammatory cascade. Now, when inflammation occurs, there is an activation of blood supply. So because the tissue that has an inflammatory response has to occur in a tissue that is vascularized, you would see some signs and symptoms of inflammation. And these are redness, heat, swelling, and pain. Now, there are three major characteristics of inflammation when there is activation of arterial capillaries and venules near to the site of injury. You would see blood vessel dilation, which is a vasodilation. This sentence right here is very important for your examination and to understand the whole inflammatory cascade and all the function of all the pro-inflammatory mediators that are released. So you would see vasodilation, you would see increased vascular permeability or leakage of fluid to the outside from the capillary to the interstitium, producing edema. You would see white blood cell adherence, which is basically migration of leukocytes to the area of inflammation, and also white blood cell adherence. So the leukocytes are the first cell that migrates and adhere to the site of inflammation and infection. and also diapedesis, which diapedesis is no more than that particular migration through the vessel walls to the site of injury that I already mentioned. So vasodilation, increased vascular permeability, and leukocyte adherence or diapedesis. Now, the effect of inflammations are seen really fast. First, you would see major or briefly vasoconstriction. So when you suffer trauma, you would see the skin that turns white. And the reason why it turns white within seconds is because there's a brief vasoconstriction episode first. Then there is blood flow and dilation of capillary venules and arterioles at the area of injury, producing vasodilation. So brief vasoconstriction followed by vasodilation, followed by increased capillary permeability and leakage of plasma from the vessels, causing swelling or edema surrounding the tissue. Now, this increased blood flow will increase the concentration of red blood cells. By increasing the concentration of red blood cells, you would see the warm tissue, the redness. In addition, there is migration, as I said, of leukocytes to the area of injury. These leukocytes will trigger several cascades or release of biochemical mediators, which you would see later on, that are histamine, bradykinin, leukotrienes, prostaglandins, tumor necrosis factor, interleukin, etc. Now, all of those, you will see that the majority of the functions that they have, if we come back here, would be vasodilation, increased capillary permeability, and diapedesis, which is the leukocyte adherence and migration to the area of infection. So, what are the goals of the second line of defense or inflammatory process? Basically is prevent infection and further damage, destroy bacteria, activating a cascade of events of proteins that would limit and control the inflammation. It would interact with other components of the adaptive immune system. You would see how they interact with each other. There's a several cascade of events that when the inflammatory process is activated, mastocytes will release pro-inflammatory mediators, including histamine. That will trigger the activation of the complement cascade that subsequently will activate the coagulation cascade, releasing the end byproduct, which is fibrin, that will contribute to healing and repair. So in addition, it will create channels through the epithelium that will activate the drainage of lymphatic vessels. Again, with as an adjuvant or in conjunction with the coagulation cascade, will initiate the mechanism of healing and repair. Now, these are the proteins that I already mentioned. So basically, the inflammation and repair can be divided in several phases. And there is an acute inflammatory response, as I told you, has a very short duration. It starts within seconds, and it could last up to 8 to 10 days from the beginning of inflammation to the onset of healing. Then we have a later phase that could take weeks to months or even years, but it has memory. So a primary and a secondary response. Now, there are several protein systems that participate in the inflammatory process for healing and repair. The first will be the complement system. Then we have the coagulation system and the kinin system. So basically, all these cascades remain inactive in plasma. There's no need to maintain an activation unless there is an infectious process or an inflammatory process. So all these proteins circulate as proenzymes, which is basically the inactive form. After they're activated, there is a sequential activation of other components that will lead to many biological functions that protects the individual. So let's start with complement system. The complement system is the most potent, destroys the pathogen directly, and defends the body against bacterial infection. So it does produce lysis. In the complement cascade, we have several pathways. We have the classical pathway, lectin pathway, and alternative pathway. In the classical pathway, we have one of the most important immune complex formation is the antigen antibody complex. So you need to know that in the classical pathway, there is a formation and activation of the antigen antibody complex, or the formation of immune complex. Now again, you know that the complement system is basically activated through inflammation and infection, but there are other components that could also activate the classical pathway, and this could be heparin, for example, or C-reactive protein. And this is the reason why C-reactive protein is a sensitive marker for or to measure inflammation. The same way is the ESR or sed rate. So it is sensitive, it's not specific, because it's released during any inflammatory or infectious process. It will never tell you exactly which specific disease the patient has. It is just released as a protein in the classical pathway of the complement system, along with the sed rate. We also have the lectin pathway, that it is not antibody dependent, so there is no formation of immune complexes, but there is an activation and formation of carbohydrate, which is called mannose, by bacterial. So it is capable, the good thing is that lectin is capable of creating pores or channels in the membrane to permit the influx of sodium and water for the cell to swell and produce cell lysis or killing. Now, the most important will, in this cascade as well, besides cell lysin, it would be not only the vasodilation, the capillary permeability, but also the induction and activation of mast cell degranulation. Mastocytes contain granules that, when mastocytes break, release these granules. These granules are full of pro-inflammatory mediators, and one of the main pro-inflammatory mediators that is released that trigger another cascade of events of anti-inflammatory or pro-inflammation is histamine. Histamine will cause vasodilation again, increase capillary permeability, and also will attract neutrophils or leukocytes to the area of infection. So histamine, besides being a pro-inflammatory mediator, is also a chemotactic factor for leukocytes to the area of inflammation. In addition, complement cascade will also trigger opsonins to be activated. Opsonins, what they do is basically they tag the microorganism for destruction. So, in other words, we have summarized all the pathways for the complement system. We have the classical pathway, that there is activation of immune complexes, antigen antibody formation. Lectin pathway, that there is activation of mannose, which is the bacterial carbohydrate. In addition to that, remember that we have cell lysis, and we have the opsonization and the activation of mast cell for the granulation and release of pro-inflammatory mediators. And lastly, we have the alternative pathway that is activated by gram-negative bacteria and fungi. So what are the end result that you need to know for your exam? So basically the function of the complement cascade is anaphylaxis, leukocyte chemotaxis, opsonization, and cell lysis. So cell lysis produced, remember, in the leptin pathway, because there is pores that are opening and there's entrance of water and swelling of the cell and burst. In addition, we have chemotaxis of leukocytes mediated by attraction of leukocytes to the area of inflammation. We also have opsonization, that, remember, the opsonization is no more than the tagging, labeling of the microorganism for destruction. And chemotaxis is no more attraction. Come in. There's inflammation, you need to start coming in to help me for repair and healing. We have another plasma protein system, which is the coagulation cascade. So this is no more than a group of protein that form the end byproduct fibrin. So it is necessary to form a fibrinose meshwork in the area of inflammation to provide or initiate repair and healing. So this fibrin will, along with platelets, will form a clot at the area of damage, that this will prevent more bacteria to attack or more foreign bodies to attack the area of inflammation and infection, and to start the repair and healing. We have an extrinsic pathway and an intrinsic pathway, if you remember in basic pathophysiology, that all of them will converge into factor 10. There's another complex of protein systems that is called quinine system. In the quinine system, we have the bradykinin. The bradykinin is one of the main products that are released in the quinine system. That, what do? If you go back to the initial stage of the PowerPoint, the vasodilation, increased capillary permeability, and edema. So the quinine system produces also activation of prostaglandin. So prostaglandin will basically stimulate nerve ending to produce pain. So besides vasodilation, increased capillary permeability, and chemotaxis or diaperesis of leukocytes to the area of inflammation, there's also activation of prostaglandin to produce pain. If you look here, we have the extrinsic pathway and the intrinsic pathway of the coagulation cascade. If you look carefully, all of them will end into factor 10 to 10A activated. There is activation of prothrombin to thrombin for the production of fibrinogen. Fibrinogen is the end byproduct of the coagulation cascade. In addition to that, there is a conversion of plasma prekallikrein to kallikrein for the formation of factor 10A, which is the Hageman factor. The kallikreins are present in saliva, sweat, tears, urine, feces, etc. Plasmin regulates clot formation by degrading fibrinogen. So there is prothrombin through thrombin, fibrin to fibrinogen for the formation of that meshwork. So, in addition to the coagulation cascade, we have natural anticoagulants that inhibit this coagulation cascade. So we have an inflammatory process um, that is activated, that activates complement cascade, coagulation cascade. But if we do not have in our body a natural inhibitor of this clotting system, we will have thrombosis all over our body and of course death because of ischemia. So we need to have naturally born with us several amount of anticoagulants, and those are protein C, protein S, lupus anticoagulant, factor 5 Leiden. We have, in addition, antithrombin 3. So again, this is the coagulation cascade, and I want you to look how all the cascades of protein systems work in interrelationship. So they have interaction among each other. So you have here the intrinsic pathway, you have the plasminogen, you have the Hageman factor, you have the quinine system, and you have the complement system as well, working in conjunction. Now, in addition, we have several mediators of inflammation, and those are the cellular components, granulocytes and agranulocytes. The granulocytes, we have the neutrophils, eosinophils, basophils. In addition, we have other cells that are agranulocytes, including your macrophages and lymphocytes or monocytes. We have the platelets as well. So, in addition to that, remember, we have other cellular membranes of the inflammatory system that one of the main cells is the mastocytes. Remember, the mastocytes will degranulate and release pro-inflammatory mediators. In addition, we have natural killer cells that can recognize and destroy cells. So now we're going to go one by one describing all these cells. But before that, let's talk about cell surface receptors. Both the innate and the acquired or adaptive immune system must recognize, remember at the beginning, the self from the non-self. And this is mediated by receptors. There is T cell receptors, B cell receptors for the B and the T lymphocytes. There is pattern recognition receptor that they recognize molecular patterns of infectious agents. We have pathogen-associated molecular pattern that produce necrosis or apoptosis. We discussed already in the cell PowerPoint that apoptosis is the program cell death. In addition, there is toll-like receptors that they're expressed in the surface of many cells, and what they basically do is have contact with potential pathogen microorganisms that are present in either the epithelium or neutrophils or these mast cells or the dendritic cell for presentation of that antigen. There's complement receptors that are granulocytes, monocytes, lymphocytes that basically what they do is they're fragmented and they activate the complement cascade. And there's also scavenger receptors that facilitate recognition and phagocytosis as well. This is not important, but you need to understand that there is receptors needed for presentation of the antigen as well as recognition of the self and non-self, and to produce phagocytosis for repair and healing. So let's talk about all the components. What is a mastocyte? Well, remember that mastocyte is a cell in tissues that releases histamine and other pro-inflammatory mediators that are involved in inflammatory and allergic reactions. So basically, it's the central cell for inflammation. It is present in the skin, in the gastrointestinal tract, and respiratory. is the one that initiates an inflammatory response. There is an antigen attacking any system of the body, such as bacteria, viruses, fungi, etc. There is recognition by these receptors. There is activation of mastocytes. Mastocytes will degranulate and all the granules are released. And this activation could be produced again not only by bacteria but also by the any physical injury, such as any heat, mechanical trauma, chemical agents such as toxins, snake venom, or again, as I told you, bacteria and viruses. So what do mastocytes release? Well, first, the first initial granule to become in contact with plasma will be histamine. And histamine is a vasoactive amine that produces, remember that the first initial response will be a brief vasoconstriction followed by vasodilation. So dilation increase capillary permeability and promote chemotaxis of leukocytes, which leukocytes or neutrophils is the first cell that migrates to the area of infection. We have several types of receptors that belong to histamine, H1 and H2 receptor. H1 is present in, it does promote inflammation, so it's a pro-inflammatory mediator, and is present in smooth muscle cells and bronchi, producing bronchoconstriction. So when a patient has asthma, H1 is the receptor that is activated. So we need to give H1 blockers like Allegra or Benadryl or Claritine to avoid the release of histamine by mastocyte degranulation and to block H1 receptors. H2 receptor is present in parietal cells of the stomach, and basically what induces is the secretion of gastric acid. So when we have heartburn, gastritis, peptic ulcer disease, the medications that we give to prevent this, the release or activation of H2 receptors and inhibition of gastric acid secretion. And this is an anti-inflammatory. In addition, with mast cell degranulation, remember that histamine will trigger the activation and also chemotaxis or calling in neutrophils or leukocytes, which are the first cell to migrate to the area of infection. Neutrophils also attract several other cells, and these are eosinophils, basophils, monocytes, macrophages, etc. So let's talk about first, before we go into the other cells, the mechanism of activation of prostaglandin and prostacyclin. When histamine is activated and the mastocytes are degranulated, begins a synthesis of other mediators of inflammation, and these are called cytokines. Cytokines include interleukin, tumor necrosis factor. Basically what they do is promote cell growth and angiogenesis. Angiogenesis is the production of new blood cells to produce that vasodilation and vascular permeability that we need. In addition, there is release of other cytokines, which are leukotrienes, prostaglandin, and platelet activator factor. Remember that with the activation of the coagulation cascade, there's also migration of platelets to the area of infection to produce that clot. Leukotrienes are a product of arachidonic acid, and what they do is basically brief smooth muscle contraction followed by vasodilation increased capillary permeability, and chemotaxis or diapedesis of neutrophils to the area of infection. Then prostaglandin is another product of arachidonic acid cascade. And what they do is the same thing: increase capillary permeability, vasodilation, chemotaxis, but also induces pain. And this is the reason why we use either NSAIDs, which are Motrin, Aleve, Advil, or aspirin, to inhibit prostaglandin to inhibit pain. In addition, there is, in addition to the inhibition of pain, mastocytes also release lysozymes. So lysozymes, remember, if you remember the cell PowerPoint, is produces autodigestion of cell debris. So along with inflammatory process and the release of all these pro-inflammatory mediators, remember, is for the purpose of initiating healing and repair. But along with healing and repair, there is production of and byproducts of metabolism of bacteria that is called debris. And these debris are digested by lysosomes and also by macrophages and monocytes by the process that's called phagocytosis. Platelet activating factor is another mastocyte pro-inflammatory mediators that is released, and is the major source of migration of platelet to the area of inflammation and infection. This is no more to project how an antigen activates the inflammatory cascade, and there is the degranulation of mastocytes, releasing all those pro-inflammatory mediators, and the first that is released is histamine, attracting the leukocytes, which is the first to migrate to the area of infection. There is also activation of the arachidonic acid pathway, and this is the cyclooxygenate and lipooxygenate cascade. The cyclooxygenate cascade will activate prostaglandin and thromboxanes, and the lipooxygenate cascade will activate leukotrienes. So giving aspirin and NSAIDs to the patient will inhibit the cyclooxygenate cascade. But be very careful when patients have any hyperresponsiveness to the airway, because aspirin and NSAID will inhibit the cyclooxygenate cascade, but it will not inhibit the lipooxygenate cascade. So therefore, patients in acute episode of bronchospasm could have worsening of the bronchospasm if you give them aspirin or any other NSAID. This is just to depict how mast cells degranulate, releasing all the granules, including histamine, and producing a chemotaxis to leukocytes to the area of inflammation. Here as well, it's very difficult to project the bottom, but you have it in your book, and it's in page 198 of the chapter Unit 3 of Mechanism of Self-Defense. You have, this is the arachidonic acid pathway. And if you look, even prostaglandin, cyclooxygenate, lipooxygenate, at the end, the result will be smooth muscle contraction briefly, followed by vasodilation, increased capillary permeability, and more diapedesis or chemotaxis of leukocytes to the area of inflammation. So what is phagocytosis? Phagocytosis is no more than digestion. So digestion of that debris, digestion of the foreign body, which is the antigen. So because the leukocytes cannot act themselves in the area of the lymph nodes, they have to leave the bloodstream and migrate to the area of inflammation. And they do this by several processes, which are called margination of pavimentation. So first, this is the leukocyte in the capillary. They need to adhere to the walls of the capillary. This is the process called margination of pavimentation. Then migrate which is called diapedesis. So it's the migration of that leukocyte through the junctions or the pores that are present in the capillary. Then by diapedesis, there is release of this endothelial cells of nitric oxide, which is another vasodilator that also promotes capillary permeability. And at the end, there is migration of the leukocytes completely to the area of inflammation. Now, this will also trigger another several steps. And the steps are opsonization, which is, remember, is the opsonization is the tagging or labeling of that foreign agent. So it's the recognition and adherence by the phagocyte. Engulfment means that trapping or ingestion by a process called endocytosis. Formation of phagosomes. Fusion of lysosome granules. And destruction, finally, of the target, which is, in this case, the antigen. So what is a neutrophil? A neutrophil is, first, remember, the predominant phagocyte of the inflammatory process is the first that migrate to the area of infection. It could take 6 to 12 hours. I'm not going to ask you any numbers, but it's the first one that migrates is a polymorphonuclear, and it's the predominant phagocyte that migrates first to the area of infection. Remember that this is the one that also attracts other pro-inflammatory mediators and other cells to the area of infection. That's called chemotaxis and diapedesis. The neutrophil is very sensitive to acidic environment, so it dies easily as well. It's the first to migrate, but it's the first to die, producing a pus as end byproduct, which is a purulent exudate that is also removed at the end by phagocytosis by the macrophages and monocytes. The monocyte is part of the immune system, produces phagocytosis, is an immature form of the macrophages, so it does develop from it. Monocytes participate in the adaptive immune system as well. It produced activation of the glucose metabolism and also lysosomes. Remember that lysosomes produced proteolytic enzymes for autodigestion. So lysosomes participate in phagocytosis. It does participate in the breaking down of macromolecules into simple subunits for the Krebs cycle. And with macrophages and monocytes, participates in phagocytosis. Eosinophils. Eosinophils are white blood cell that kills bacteria, but more importantly are mobilized by parasites and allergic reactions. So when you see eosinophiles, these are mainly activated by parasites and allergic reactions. We have, in addition, natural killer cells that they recognize and eliminate an infective virus. But this is in conjunction with interferon. So also differentiates infected or tumor cells from a normal cell. Platelets. Platelets, remember, that are one of the cells that in conjunction with the coagulation cascade migrate to the area of injury to produce the clot. Then we have interleukins. Interleukin is a pro or an anti-inflammatory pyrogen. Interleukin produces fever along with the tumor necrosis factor. So it's a messenger for macrophages and lymphocytes to be attracted to the area of inflammation and infection, enhances immune response, and it does participate as well, not only in the innate, but in the adaptive immune system. These are called, remember, cytokines. Cytokines are interleukin and interferon. Interferon, more than interleukin, protects the body against viral infections. So when you hear eosinophils, it's for allergic reactions and parasites. When you hear interferon, it protects the body against viral infection. That's the reason why you get not transfusion, but infusions of interferon or injection of interferon when the patient have a viral infection. Then in addition, we have, along with other cytokines, this is no more than a picture of it, of the interferon. How does it attack virals? Tumor necrosis factor. Tumor necrosis factor basically is a pro-inflammatory mediator as well that is present in the endothelial cells, produces fever, increases pro-inflammation in the liver, causes muscle wasting. So the most relevant factors here is fever, muscle wasting and cachexia, and also thrombosis. So when the patient has sepsis and septic shock, this tumor necrosis factor is the one that produces high levels of fever, catabolism and cachexia, and even clot forming. These are all the interleukins. If you look, all the interleukins, when they interrelate, they have the same function. Leakage, endothelial adherence, vasodilation, growth and proliferation, and induces collagen formation for healing and repair. So what are the local manifestations of inflammation? We discussed that it's basically warm or heatedness, redness, produced by vasodilation and increased blood flow. Then we have swelling, and this is no more by the capillary permeability and edema and the exudate that is formed. We also have pain that is exerted by pressure and prostaglandins and bradykinin, as we discussed. This exudate that is formed in this phase of swelling, it could be serous, which is watery and indicates early inflammation. It could be fibrinous, which is thick, purulent, that indicates bacterial infection, or hemorrhagic, that is obvious, indicates bleeding. Now, what are the systemic manifestations of inflammation? There is fever, leukocytosis, and activation of all the inflammatory cascade that, if you remember, in the second phase, we have release of C-reactive protein. We also have release of citrate, and in addition, we have haptoglobin. Haptoglobin is an indicator of inflammation, but it's also an indicator of lysis of cells. So if you're looking for hemolysis, for example, haptoglobin is released during hemolysis. Now let's talk about left shift before we go into chronic inflammation, because this is going to be on your exam. When a patient comes in with leukocytosis, WBC is elevated, more than 10,000, you look for immature cells being formed, or bands, B-A-N-D-S. So the formation or the presence of bands, which is the immature cell of the neutrophils, is called left shift. And left shift is an indication of bacterial infection. When the patient has more prominent lymphocytes instead of neutrophils, it's called right shift, and it's an indication for viral infection. This is a question. Now, chronic inflammation is present when the inflammatory process is being prolonged more than 2 weeks, or 2 weeks or longer. And remember, it's it doesn't have to be necessarily preceded by an acute inflammatory process, but it's an indication of the inflammatory process, everything that we have discussed already, has been unsuccessful. And basically, it could be in relationship to the ability to survive inside the macrophage. So the bacteria has survived all the inflammatory process and all the activation of cascade, depending on resistance of the toxin, any continuous chemical or physical irritant that is present in the inflammatory site. Um, there's also formation of granuloma. And what is granuloma? When there's a dense infiltration of lymphocytes and macrophages, the body tries to wall off or isolate the infected area. And this is with the formation of granuloma. So whenever you see the presence of a granuloma, that granuloma means chronic inflammation. And we see that in the abdomen, we see it in the lung, we see it in the adrenal glands. So basically are markers of chronic inflammation. And this is because neutrophils and macrophages and the whole cascade of events in the inflammatory process have been unable to destroy the microorganism. Now, for repairing, resolution of repair, let's talk about concepts first and then we go through the phases. There is the most favorable outcome for tissue repair and healing is the process called regeneration. Regeneration is the complete return to normal structure and function. And this happens if there is damage that is really minor. There's no complications. So there is complete resolution. Now, complete resolution is returning to the original structure and function. There's also repair, that is the replacement of destroyed tissue with scar tissue. And this scar tissue is primarily composed by collagen. Now, the wound in this case will return only tensile strength, but the physiological function of the tissue could be destroyed. Then there's a process called debridement. That, remember, debridement is no more than cleaning. Is the phagocytosis that takes place by either monocytes and macrophages of end byproducts. And there's healing, that the healing basically fills in, seals, and shrink the wound. The healing process could be by primary or secondary intention. The primary intention is when there is minimal loss of tissue. You have a very clean line incision, and the body repairs by primary intention. Or when you suture, that is healing by primary intention. So there is borders that are well approximated and there is no major inflammation or infectious process. Now, when there's an open wound or there is ragged borders, there is a major epithelialization and scar formation with even contraction of the wound. And this is basically healing by secondary intention. Or when the wound was already by primary intention and produces a secondary infectious process, an abscess, and wound dehisce, or the suture goes away, that's called dehiscement. The wound has to be left off for secondary intention healing. Now there's phases for resolution and repair. The first phase is called reconstructive, that begins 3 to 4 days after the initial injury. And there is the production of fibroblasts, collagen synthesis, and epithelialization and contraction. Then the last phase is called maturation phase, that begins several weeks after the injury and even could be completed up to two years. In some books it says 3 years. During this phase, there is cellular differentiation, scar tissue formation, and remodeling. So again, in the reconstruction phase, there is epithelialization that includes formation of granulation tissue. There is migration of fibroblasts. There is collagen synthesis and secretion. And the contraction begins and differentiates. And in the maturation phase that could take years, there is completion of contraction, and there is differentiation or remodeling of the scar tissue and disappearance of capillaries from the scar tissue. Now, there are several dysfunctions of healing process, and this could occur, or the wound does not heal properly or within time, because there's possible hemorrhage or infection, or the wound dehisced. There is more fibrous tissue adhesion producing a keloid. There is an excess of scar. There is sepsis, low volume, hypovolemia, or hypoproteinemia, so malnutrition. Diabetes is another factor. Prolonged use of anti-inflammatory steroids is another factor. And in the malnutrition could be deficiency of iron, copper, calcium, for example, zinc. Now, there is when there is impaired collagen matrix, we could have the presence of a keloid scar or a hypertrophic scar. A keloid is basically a raised scar that extends beyond the original boundaries. And hypertrophic scar is a raised also, but remains within the original boundaries of the wound. Now, we talked about this already. Now, this is a picture of a dysfunctional wound healing, which is a keloid. Now, the histency is no more than a complication of a healing wound that sutures that were closed separate. That's called the histens. And could be due to excessive strain. It could be due to obesity. It could be due to infectious process. It could be due because there is a hematoma underneath the skin. And also this will increase the risk of more bacterial attacking the incision and superimposed infection and sepsis. Now let's talk about inflammatory process and healing process in the pediatric and elderly population. Remember that the immune system is transiently depressed and immature for neonates, so it could be delayed, the healing process. The neutrophils are not capable of chemotaxis. The neonates will express complement cascade deficiency, and also because the collectins and adhesins are immature as well. So pediatric and elderly population would have the healing process will be delayed due to immature immune system. But in the elderly population, even though it is mature, there is the decline and also chronic illnesses that are superimposed that delayed healing. This is such as diabetes, if you have cardiovascular diseases producing hypovolemia or impeding a good blood flow to the area of infection, of inflammation, that would delay healing. Also, there is a decrease of pro-inflammatory mediators migration, and also loss of regeneration ability of the skin to heal properly. This is the end of this PowerPoint. Now we will discuss the adaptive immune system. In addition, we will talk about stress and disease and infectious process.